Hello everyone. So today in this video our topic of discussion would be sports injuries, particularly the sports injuries around knee, right? So this is quite an important topic as far as NEET PG is concerned as well as INI-CET is concerned. In fact, you will notice that multiple questions are being asked year over year repeatedly in INI-CET. So this topic is very important if you are aspiring for AIIMS PG entrance examination, right? So let's start. Basically, injuries are can be classified into two types: the high velocity injuries and low velocity injuries. High velocity injuries are typically seen due to road traffic accidents, right? So while low velocity injuries are usually sports injuries. Now high velocity injuries due to road traffic accidents and other sort of high velocity trauma typically lead to fractures involving bone, right? So fractures we have studied all across orthopedics, but in sports injuries, what you see more commonly is tendon and ligament injury. So strains and sprains. Now how to remember what is strain and what is sprain? Basically strain में T आता है, strain has T, while tendon also has T. So strain stands for tendon injury, while sprain is ligament injury. So that's how you remember, right? Now most common type of strain, the most common type of tendon injury which is seen clinically is supraspinatus tendon injury, followed by tendo-Achilles tendon injury, right? So this is also important how to remember it. S comes first, S before T. So S is also more common, while T is second most common. That's how you can remember, right? The most common strain is supraspinatus followed by tendo-Achilles. While in sprain, the ligament injury, most common type of sprain is ankle sprain, and the associated injury is the injury of anterior talofibular ligament. Right, so that much you have to remember. The most common strain is supraspinatus tendon injury followed by tendo-Achilles. Most common sprain, ankle sprain associated with anterior talofibular ligament injury. Right, now we have here tendo-Achilles tendon injury. Right, tendo-Achilles, you can call it tendo-Achilles tear or tendo-Achilles injury or tendo-Achilles disruption, whatever. All are essentially the same thing. So two important things which you must remember, and questions are framed around that. That is how to test for what is the clinical test for it. So the clinical test to check for tendo-Achilles tear is Thompson test, right? So this is important potential question. And second one is the classification used for tendo-Achilles tear. So that is the Kuvada classification. That is also important, and you must remember it. This though is, you must remember, like, questions have been asked in the past and will be asked in future as well. So Thompson test is particularly important, and you also must know how to perform it in clinic, right? So what we do is basically is the calf, which is comprised by the bulk of soleus muscle, right? The soleus muscle comprises the bulk of the calf, right? So we squeeze it gently, and on squeezing the calf, if there is a movement of foot towards the ground, right? If the calf squeeze moves the foot, then the Achilles tendon is not fully ruptured, right? But if the calf squeeze does not move the foot, then there is a full Achilles tendon rupture between the soleus muscle and the heel bone. So this is known as the calf squeeze test or the Thompson test for Achilles tendon rupture. That is, on squeezing the calf, which comprises mainly of the bulk of soleus muscle, if there is plantar flexion of the foot, that means Achilles tendon is okay. But if there is no plantar flexion, even after compressing the calf, that suggests कि जो Achilles tendon है, that is ruptured. That's why the foot is not moving on. That is, foot is not showing passive plantar flexion on compressing the calf muscles, right? So that completes the first topic. All right, so let's move on to the second heading, the anatomy of the knee joint. Now, as far as knee joint is concerned, there are multiple ligaments, right? Like the fibrous capsule, the oblique popliteal ligament, the arcuate popliteal ligament, and so on and so forth. But as far as our topic is concerned, we are concerned with 6 ligaments, right? These 6 ligaments are clinically relevant, and also we must know about their patterns of injury, their investigations, their clinical tests, and the treatments for these ligament tears. So these 6 ligaments can be grouped as the extracapsular ligaments and the intracapsular ligament. So the extracapsular ligament has basically 2 ligaments: the medial and lateral collateral ligaments. right? While intracapsular ligaments are the remaining four, again which are grouped into two groups: the intrasynovial and extrasynovial. The menisci are intrasynovial, the medial and lateral menisci, while the cruciate ligaments, the anterior and posterior cruciate ligaments, are extrasynovial ligaments, right? So these are the six ligaments which are clinically important as far as sports injuries around the knee joint are concerned, right? So now moving on to these anatomical diagrams. These anatomical diagrams are not important, right? What's actually asked in exam is the MRI images of the knee joint, and there you have to make out which joint is injured. Which ligament in the shown MRI of the knee joint is injured, and also they can mark using an arrow the ligament, and they might ask you which ligament is this, and then you have to identify that ligament in the MRI image. So that sort of questions are asked, right? So so as far as this anatomical image is concerned, you must know to identify where the ligaments are actually located. So that will also help you identifying the said ligament in the MRI, right? So here is the anterior view of the knee joint. So in the anterior view, uh, the fibrous capsule has been removed. So all the ligaments located inside the fibrous capsule are visible to us. So on the lateral most aspect and on the medial most aspect, we will see the collateral ligaments. So this right here is the medial collateral ligament on the medial most aspect, and on the lateral most aspect you will see the lateral collateral ligament. So these collateral ligaments are pretty easy to identify. Then you will find the cruciate ligaments. These are the two ligaments which are going in a crisscross pattern, as you can see, right? They are going in a crisscross pattern. So of course the one which lies anterior is the anterior cruciate ligament, and the one lying behind the anterior cruciate ligament is the posterior cruciate ligament. So the collateral ligaments on the medial and lateral aspects, and then the cruciate ligaments, which, as the name suggests, cruciate literally means like a cross. So cruciate ligaments grow in a crisscross pattern. And one on the anterior is the anterior cruciate, and behind it lies the posterior cruciate ligament, right? Then this is the image of this is also the image of knee joint, although this is the superior view, right? This was the anterior view. This is the superior view of the knee joint, and this is the tibial plateau, the basically the superior aspect of the head of tibia. So here you can see the menisci, the C-shaped or the horseshoe-shaped ligaments. So these are the menisci. Of course, the one on the medial is the medial meniscus, while one on the lateral side is the lateral meniscus. If you are not able to figure out the medial and lateral aspect of the tibia itself, then also you can make them out as the medial meniscus lies slightly anterior, as you can see, while the lateral meniscus lies slightly posterior. Right. This on the anterior aspect is the tibial tuberosity. So the medial menisci would be seen slightly anterior, and the lateral menisci is slightly posterior. So that's how the menisci are visible on the superior view. Collateral and cruciate we saw on the anterior view already. So that's how the appearance is. Now this image particularly is important, right? So what basically the question comes is the sequence of attachment of these ligaments on the superior part of tibia from anterior to posterior. This image, so this image and this image, right, are basically the same images, right? Basically in this we are concerned with the sequence of ligaments from anterior to posterior. Although we have already, these are basically the same images. These are the menisci, as you can see, right? So here the focus is on the sequence. So the anterior most lies the anterior horn of medial meniscus. After that lies the anterior cruciate ligament. Third is the anterior horn of medial meniscus. Fourth is the posterior horn of medial meniscus. Then comes the third and four are the anterior and posterior horn of lateral meniscus. Then fifth is the posterior horn of the medial meniscus, and then finally on the most posterior aspect is the posterior cruciate ligament. So this is the sequence of ligaments attached on the superior aspect of the tibial plateau, right? So the anterior most, once again we will see the anterior most is the anterior horn of medial meniscus. then the anterior cruciate ligament, then the anterior horn of lateral meniscus, then the posterior horn of lateral meniscus, then the posterior horn of medial meniscus, and the posterior most is the posterior cruciate ligament. So this is the sequence from anterior to posterior, right? Next, next, yeah. So basically, for any sports injuries, the investigation of choice is MRI, right? So whether it's collateral injury, whether it's menisci injury, or whether it's cruciate ligament injury, the investigation of choice is MRI. Although if they ask what is the gold standard for sports injuries, then it is arthroscopy. But also one important thing to remember here is that arthroscopy can be done only for intracapsular ligament injury, right? That means if they give you a question in which the medial collateral or the lateral collateral ligament is injured, and they ask you what is the and they ask you about the investigation, then you cannot mark arthroscopy, right? Arthroscopy is gold standard investigation, no doubt, but it is only for intracapsular ligaments. It is of no use in collateral ligament injury or in general extracapsular injury of the knee joint, right? Arthroscopy is used for intracapsular ligament injury, that is menisci injury slash cruciate ligament injury, right? So that completes the second part. Now moving on to the third part. So this is the main content of this whole video, the ligament injury, right? So starting with the collateral ligaments. Please note that we will follow a certain pattern here. We will first look for what is the function of the ligament which we're talking about. Then we will move on to the mechanism of injury or the type of force which led to the ligament injury. Then we talk about certain clinical features or whatever certain special features which that ligament injury has. Then we will talk about the investigation, finally the management, and that's how we will go, right? So starting with the collateral ligaments, function of the collateral ligament is providing stability in the coronal plane, right? So they provide coronal plane stability, right? So this plane, this is the coronal plane, right? For more clarity, you can understand it like this: that this is the superior direction, this is the inferior direction, this is the medial direction, and this is the lateral direction. So this plane, the plane which is formed, is the coronal plane. So stability in coronal plane is provided by the collateral. So what type of force will cause collateral ligament injury? Of course, varus force or the valgus force, right? So if there is a forceful varus uh, movement of the leg at the knee joint, right? If the leg is pushed medially in the coronal plane, that will lead to stretching of the lateral collateral ligament, and if the force is severe enough, then it might lead to what? Lateral collateral ligament tear. Similarly, if the leg is pushed laterally, that is, there is a forceful valgus stress at the knee joint, then it would lead to stretching of the medial collateral ligament, and if the force is severe enough, it might lead to what? A medial collateral ligament tear, right? So that's what there is. Forceful varus leads to LCL tear, forceful valgus leads to MCL tear. So I don't think we need a mnemonic to remember this, it's pretty self-explanatory. All you need to know is that collateral ligaments provide stability in the coronal plane, right? So so the function itself explains the type of force which leads to the ligament injury, right? Now coming on to the clinical features, of course MCL injury is more common than LCL injury, that you have to remember. In fact, medial collateral ligament is the most common injured ligament around the knee, right? So any sports injury around the knee, the most common ligament which gets injured is the medial collateral ligament, right? That you have to remember. Now, of course, the pain in MCL injury, the knee pain will be more on the medial side, while in LCL injury, the pain will be more on the lateral side of the knee, right? For clinical test, we have the valgus stress test and varus stress test. Now, of course, forceful valgus leads to MCL tear, so valgus stress test will be for MCL injury. Since forceful varus force leads to LCL tear, varus stress test is for LCL injury, right? Now, one important thing to remember is that we do these tests at 30-degree knee flexion, right? 30-degree knee flexion. Why do we do this? It is done so as to rule out other other ligament injuries, right? So as to prevent any false positive, we want to do the valgus and varus stress test to check the tear of medial or lateral collateral ligament. So if we have to rule out other ligament injuries, we have to do these tests at 30-degree knee flexion, right? So this is a small point to remember. Now valgus stress test is self-explanatory, that we push the leg towards the lateral side in the coronal plane. So right, we give a valgus stress, and if the patient complains of pain at the knee, then it's suggestive of an MCL injury or MCL tear. In varus stress test, we basically push the leg medially in the coronal plane at the knee joint, and if the patient complains of pain at the lateral aspect of knee, then that's suggestive of lateral collateral ligament injury, right? So basically, forceful valgus causes MCL tear, that's why we use the valgus stress test. Forceful varus causes LCL tear, we use the varus stress test, right? So that's pretty simple. Moving on to the management and investigations. So management, as we know, the investigation of choice for all sports injuries is MRI, right? So for collateral ligaments, we use the coronal view MRI, right? So the view is important. For other ligaments, we will use other view, for some sagittal view, for some different view. But for collateral ligament injury, MRI knee joint and coronal view is taken, right? So as you can see, this is the medial and this is the lateral side. Now this is the lateral collateral ligament and this is the medial collateral ligament. Typically that MCL tear is associated with edema. As you can see, there's some sort of bulge visible here as compared on the medial side as compared to the lateral side. So that's how you diagnose MCL tear on MRI of the knee joint, right? Now in terms of treatment, in 90% cases, only a conservative brace is needed. Only in 10% cases do we need surgical management of the ligament tear. All right. So that's all we need to know about collateral ligament injury. Second, we have the injury to menisci. So meniscal ligament injury, basically menisci are semilunar structure. We already talked about that. They are C-shaped or horseshoe-shaped or semilunar shaped structure, and they consist of type 1 collagen, right? So coming on again, talking about the function of menisci, basically they are shock absorber and most importantly a rotational stabilizer. That is, they stabilize the knee joint, preventing excess twisting, torsion, or rotation. So of course, the type of force which will lead to a meniscal injury would be torsional force or forceful twisting. That is, excess rotational movement at knee joint, excess torsional or excess twisting of knee joint will lead to injury to the menisci, right? The most common type of injury is bucket handle tear. So that's again you have to remember only. Now, as we saw in collateral ligament, MCL injury was much more common than LCL injury. So here also, medial meniscus injury is much more common than lateral meniscus injury. All right. Coming to the clinical features, the characteristic feature is delayed onset of knee pain, right? Delayed onset of knee pain, if the history mentions, then you must suspect menisci ligament tear, right? Delayed onset of knee pain, and since these are intrasynovial structures, we talked about that key menisci are intrasynovial, intracapsular and intrasynovial. So of course their injury will be associated with joint infusion of synovial fluid, joint effusion, mild to moderate joint effusion, and this will present as joint swelling. All right. Also, they have a characteristic feature which is pathological locking of knee in incomplete extension. Why this occurs? This occurs due to trapping of the fragment of menisci between the tibial and femoral condyles, right? So this leads to pathological locking of the knee. So all these are clinical features: delayed onset of knee pain, delayed onset swelling due to mild to moderate joint effusion, and pathological locking of knee due to trapping of meniscal fragment between the tibial and femoral condyle. So these are the clinical features which you have to remember. Moving on to the clinical examination and the clinical tests. Right, this is the important part, right? This is where from where the questions are asked every year almost, right? So we have basically 4 5 tests here. First is the McMurray's test, right? McMurray's test. What we do here, the sequence is first we do a hyperflex the knee. First we hyperflex the knee, then we perform the maneuver. The maneuver is essentially internal or external rotation plus valgus or varus force, and then finally we extend the knee back into the natural position, right? So patient is asked to lay supine on the bed and then start with hyperflexion, perform the maneuver internal rotation plus varus or external rotation plus valgus, and then extend the knee back to the natural position, right? So if there is if on internal rotation plus varus force you hear a click sound or the patient reports of pain, increase in pain, right, then that is suggestive of lateral meniscus injury. If external rotation plus valgus force leads to a click sound or a leads to pain, then that is suggestive of medial meniscus injury, right? So this is similar to collateral ligament also, which we saw. Key valgus stress test, which what we saw there was uh, valgus stress test was for MCL injury and varus stress test was for LCL injury, right? So same way here, valgus force, अगर valgus force पे pain हो रहा है that is suggestive of medial meniscus injury. If varus force plus internal rotation पे pain हो रहा है then that is suggestive of lateral meniscus injury. So you can sort of remember this uh, valgus stress test or valgus force in McMurray's test related to medial. It could be MCL or medial meniscus. Similarly, varus stress test or varus force given with internal rotation in McMurray's test, it is associated with lateral. It could be LCL in case of varus stress test, or it could be lateral meniscus in case of McMurray's test, varus force plus internal rotation, right? Now second test is Epley's grinding test. Epley's grinding test, very simple, easy to remember. Ask the patient to lay prone on the bed and flex the knee to 90-degree position, and then rotate the menisci between tibial and femoral condyle plus push the tibia towards the tibia. So if the patient reports of pain, that is a positive test and suggestive of menisci injury, right? Third is the joint line tenderness test. This is the best test, right? So this you have to remember. Fourth is the Thesales test. This test is similar to Apley's grinding test only, and this what we do is patient is asked to stand on one leg. Patient is asked to stand on the affected leg, right, and then asked to twist their body. And so if the patient complains of pain on such maneuver, then that is and that is suggestive of positive test and suggestive of meniscal injury. Fifth is e-gaze test. Here you just need to remember the name, no need to remember the details of the test, right? So McMurray's test, Apley's grinding test, joint line tenderness, which is the best test, the Sally's test, and e-gaze test. McMurray's test में you have to remember valgus force and external rotation पे अगर पेन होता है then that is suggestive of medial meniscus injury. Varus force और plus internal rotation पे पेन होता है then that is suggestive of lateral meniscus injury. Similarly, valgus stress test is for medial collateral ligament. Varus stress test is for lateral collateral ligament. So both things are similarly linked. So remembering them will be easy that way, right? Now coming on to the investigations and management. Okay, so basically, as we studied earlier, investigation of choice for all sport injuries is MRI, but in case of menisci, we use the sagittal view. In collateral ligament, we use the coronal view, but in menisci, we will use the sagittal view. So basically, we are taking a slice from cutting the joint in this way and seeing from the side. So this is what the view looks like, and here you will see two these circle like structures. So these two dark circles are basically the anterior and posterior horn of the menisci, right? So basically when we see tibia from the superior in superior aspect, we see the this is like the medial meniscus, and this is the lateral meniscus. So when we are taking a sagittal flexion, this means we are cutting the joint cavity in this way. So and viewing from this side, then we will see this and this is the anterior horn, this is the posterior horn, and from this side the view looks like this. So this is what you see in the sagittal view MRI of the knee joint. These are the anterior and posterior horn of the menisci are visible. All right. So there is that. Also, obviously, the gold standard investigation is arthroscopy, as we talked about earlier. That for intracapsular sports injuries, we can use arthroscopy, which is the gold standard, right? Now, coming on to the treatment. Um, so Okay. Now coming on to the treatment, for to study the treatment of meniscal tear, we need to know the vascular supply of the menisci, right? So basically, the peripheral part of the meniscus gets blood supply from the genicular vessel, right? But the central part, this part, right, this part of the menisci, this white colored part, this red colored part gets supply from the genicular vessel, right? But the central part doesn't have a dedicated blood supply. It absorbs nutrition directly from the synovial fluid. So of course, the one which has a proper blood supply, the peripheral part, it will have better healing, right? While the central part will be slow to heal because it has to absorb the nutrition from synovial fluid. So, that's how we divide the meniscal ligament into three zones. The peripheral well vascularized zone is called the red zone. The central poorly vascularized zone is called the white zone, and the middle zone is called the red white zone. So three zones of meniscal ligament. Based on where the injury is, we decide the treatment. So if based on location of meniscus injury, we decide the treatment. So if injury is of the red zone, it has the best healing. So what you do is, the treatment of choice is here is repair. Repair means meniscorrhaphy and meniscopexy. But when the injury is of the white zone has poor healing because it has no dedicated blood supply like the peripheral zone, which has auricular vessel. But the central zone or the white zone has to absorb nutrition from the synovial fluid. So the treatment of choice here is not repair but resection of the affected part. Hence, the treatment of choice here is meniscectomy, while here it is meniscorrhaphy and meniscopexy. So, based on where the injury is in the meniscal ligament, we decide the treatment option. Okay, so now we begin with the injury to cruciate ligament, right? So, once again, the function of cruciate ligament is they are stabilizers of the knee joint in the sagittal plane. So, they are sagittal plane stabilizers, right? So the anterior cruciate ligament prevents the translocation of tibia anteriorly and thus prevents hyperextension of knee joint. Posterior cruciate ligament prevents the translocation of tibia posteriorly and thus prevents hyperflexion of the knee joint, right? So this is the function. So from the function itself, it's pretty clear that what sort of force will cause the injury to cruciate ligament. If there is forceful anterior translocation or hyperextension of knee joint, that will lead to what? It will lead to ACL tear. If there is forced posterior translocation of tibia or there is hyperflexion of the knee joint, that would lead to a posterior cruciate ligament tear, PCL tear. Now, this forceful anterior translocation of tibia or hyperextension, this type of movement is typically seen in sudden pivoting or cutting movement or cutting maneuver used by footballers, right? So in certain contact sports like football, you might have heard commonly that so and so footballer got an ACL tear and now they will have to stay off the field for the next 9 to 10 months. So ACL tear is quite a big concern for football players and in general any contact sports players, right? So it's quite common in those fields. Now, clinical features. Yeah. So cruciate ligament injury will present with an acute onset of pain and twisting injury to knee with a pop. Yeah, so that's a common presentation. The patient would have heard a pop sound, right, due to the injury to cruciate ligament, and it is associated with hemarthrosis since it is intracapsular structure, right? Intracapsular ligament. That means any injury to the cruciate ligament might present with a hemarthrosis, that is collection of blood in the joint capsule, and the patient might have some instability on walking, right? So next we have the examination in which we will see the clinical tests which are relevant for cruciate ligament injury. So for ACL injury we have the anterior drawer test. Anterior drawer test, what we do is we flex the knee to 90 degrees position, right, like this. The hip is flexed at 45-degree angle and the knee is flexed at 90-degree angle, right? And then we perform an anterior translocation of tibia. If the tibia translocation, anterior tibial translocation is possible for more than 3 mm, then that is suggestive of an ACL tear, right? Although this test is not so good because even in an acute knee injury, the pain and spasm of the surrounding muscles itself inhibits anterior translocation, anterior translation of the tibia. So this might give you false results. That's why anterior draw test is not so sensitive test, and the best test is in fact Lachman's test. This is similar to anterior draw test, except in here the anterior translocation of tibia is done at a 15 to 20-degree flexion of knee, compared from anterior draw test where we do the same maneuver at 90-degree flexion of knee. So Lachman's test is the best test or the most sensitive test for ACL tear. Then we have the pivot shift test. This is the most specific test for ACL injury, right? Similarly, for PCL tear, we have the posterior drawer test. Posterior drawer test is the opposite, is just the opposite of anterior drawer. Here also we flex the knee by 90-degree and then try to translate the tibia posteriorly. If posterior translation of tibia is more than 3 mm, and that is suggestive of PCL tear. Another is the Godfrey's sac test. It is preferred in unilateral injury to the knee joint, right? Once again, 90-degree flexion at both hip and knee joint, right? So both these angles are 90-degree, and then as the name suggests, it's a sag test. Thus, the tibia sags down, right? So there is posterior translation of the tibia due to gravity itself. We don't need to even apply force, right? So tibia sags by itself. uh, so that's how you do the Godfrey sag test. Coming on to the management of cruciate ligament tear. Of course, yeah, investigation of choice is MRI as for all sports injuries. Although being an intracapsular joint, the gold standard investigation of choice is arthroscopy, right? Now MRI, which MRI here also we do the sagittal view of the knee joint. So as you can see, this is the femur, this is the tibia, this is the patella, and this dark structure, this is the anterior cruciate ligament, right? So that's how it looks, and this structure, this is the posterior cruciate ligament. So you should be able to make out the ACL and PCL on a sagittal view MRI of the knee joint, right? Coming on to the treatment is arthroscopic reconstruction with grafts. And which grafts do we use? We either use the hamstring graft, the semitendinosus graft, gracilis graft, or we can use the patellar tendon graft, right? So arthroscopic reconstruction is done using grafts from either the hamstring muscles, semitendinosus gracilis, or using the patellar tendon graft. Alright, so this completes the third section. So let's begin the final section. These are some miscellaneous points. First is arthroscopy, right? So arthroscopy most commonly performed on knee joint, right? Now, yeah, the question can be asked here, that is, uh, from which port there are basically two types of portal, right? Anteromedial portal and anterolateral portal, two portals which are used in arthroscopy. So from the anteromedial portal we insert the instruments. The anteromedial portal is used for instrumentation, while the anterolateral portal is used for arthroscope itself. And what type of scope is used? 4 mm 30-degree scope is used, right? So here is a mnemonic for that, that is MILA. so arthroscope मिला, ठीक है. Anteromedial portal is for instrumentation and anterolateral port is for arthroscope itself. So arthroscope mila, that is the mnemonic to remember from which portal what do we insert. Arthroscopy most commonly done on knee joint followed by shoulder joint, right? Then second point, anterior cruciate ligament, it has two bundles, the posterolateral bundle and the anteromedial bundle. So you just have to remember this. There is no understanding part here. Anteromedial bundle helps maintaining stability during flexion, while posterolateral bundle helps maintain stability in extension. ACL tear, anteromedial bundle involved in complete tear. This is involved in partial tear. And test for posterolateral Lachman's test, and for anteromedial anterior drawer test. So this is not that important. Finally, second fracture. Second fracture is important. So basically, second fracture is nothing but a capsular avulsion in the proximal lateral aspect of tibia, right? And it is associated with ACL tear. Then we have the unhappy triad, painful triad, terrible triad, or Odenhog triad of the knee. This is very important, right? It has been asked previously. So what happens here is that uh, three ligaments are injured simultaneously. Which three ligaments? The medial collateral ligament, the medial meniscus, and the anterior cruciate. So MMA. That's how you remember, right? So medial collateral, medial meniscus, and anterior cruciate ligament MMA. That is how you remember. And the mechanism of injury is basically the knee is flexed, the leg is fixed on the ground, and there is medial rotation of femur and valgus force on tibia, right? So this is the direction of force. Direction of force is from lateral to medial, which leads to valgus force on tibia, which causes the terrible triad injury. All right. So what the important part here is this: which all ligaments are involved? Medial collateral, medial meniscus, and the anterior cruciate. All right. Then we have the Insel Salvati index. So Insel Salvati index to assess patellar instability. It is the ratio of tendon length to patellar length, right? So basically this is the ligamentum patelli or the patellar tendon, right? And this is the patella. So the ratio of tendon length to patellar length is equal to this index, and the normal range should be 0.8 to 1.2, right? So if it is more than 1.2, it means the tendon length is more and related to patellar length. That means so that condition is called as patella alta, and this leads to recurrent patellar dislocation. Tendon length is this ratio is less than zero point 0.8. This means tendon length is shorter compared to the patellar length. This is known as patella baja. Alta basically means above, right? So if tendon is longer, that means patella is located slightly above, and if the tendon is shorter, that is baha. Baha means below. That means patella hangs below. Patella is lying below, right? Patella is slightly longer up to this point, so that is known as patella baha. So if the tendon is longer, that is suggestive of ratio more than 1.2, patella alta, recurrent patellar dislocation. If tendon is short related to patella, the ratio would be less than 0.8, and the condition is known as patella baha, right? Finally, 6 point, injury due to rotational instability, right? Once again, just remember, posterolateral rotatory instability is due to PCL injury or posterolateral corner structure injury. Anterolateral rotatory instability is due to ACL injury or anterolateral ligament complex injury. For anterolateral rotatory instability, we use the pivot shift test. For posterolateral rotatory instability, we use the dial test. So that's all there is, and this completes the sports injuries chapter. So thanks for watching. See you in the next video.